Good afternoon. Welcome to everyone. So good to see so many names, so many people popping in. Welcome, welcome, welcome. And happy Monday. So today we have our resilience and well-being for the educator part 2. This was a highly requested second session. So it's a little bonus session. It's going to be very discussion oriented today. There's a lot to get through, but please, if you'd like to make a comment or have a question or concern, feel free to either unmute yourself and put your video on if you want, either or, or go ahead and type something in the chat box, and we're happy to facilitate the chat function for our presenters today. So today we have Dr. David Musick, our Senior Dean for Faculty Affairs, and Emily Holt-Forst, our Director of Academic Counseling and Enrichment Services at the medical school. Sandy will, throughout the presentation, for at least the first half hour of the presentation, she's going to go ahead and put the links for the evaluation form for you all to claim CME and or faculty development related to teaching. So without further ado, I'm going to turn it over to our presenters. Enjoy this session.
Thank you very much, Dr. Wicker. It's a pleasure to be here for part 2. I want to start by telling you that I've been having some issues with my computer audio. I have a support ticket in, but they haven't gotten to me yet. So occasionally, hopefully this is not going to happen, but if my audio cuts out for a few words, we'll just try to make the best of it. I can't tell when it happens, but hopefully if I miss anything important, I can go back and restate it or do something about that. So we'll jump right in here. As we're providing continuing education credit today, it's necessary to put up a disclosure slide, and neither Emily or myself have anything relevant to disclose, as noted on this colorful graphic here. We often say in education research, we wish we had something to disclose, but we don't have anything today. Okay. Hopefully by the end of this time, you'll be able to describe at least some of the factors that have an influence on resilience and well-being at the 3 different levels that we're going to talk about: the individual level, the team level, and system levels. We also hope you'll be able to describe at least some strategies and resources that you can use to enhance your own well-being, or the well-being of your team, or the well-being of our organization at the system level. I want to expose you to 3 model programs that we have researched and feel like really are setting the trends and are out in front in terms of what they're doing to enhance the well-being of folks in their academic medical centers. So we'll introduce you to those, with the ability to identify a well-being champion for your team or your department. So those are our objectives today. They're pretty ambitious. We hope we can get through all of them. We do want this to be to meet your needs. So please interject with questions, comments, feedback, or opinions at any time, and we'll do the best we can. If we don't get through all the material, then we don't get through it, and it's no big deal. It'll all be posted online for your review later on. We want to start today by pointing out or doing a little bit of review from our May the 4th session. And at that time, we had this slide where we talked about 2 different things. We talked about the definition of burnout, which appears on the right-hand portion of this slide, and then also a broader construct called professional distress. And really what we need to think about and talk about when we're talking about burnout is this larger construct, which includes not just burnout, but depression, stress, work-life integration, professional satisfaction, fatigue. We also like to talk about faculty vitality and well-being. So we don't want to just focus on the term burnout, but we want to talk about what can we do to increase our opportunities to experience as little professional distress as we can, and at the same time, do well in regard to the issue of burnout. I also want to point out very carefully that although a lot of our comments today are going to be focused really on our clinical faculty and our clinical colleagues, we don't want you to come away from this with the idea that this is not a message that applies to our non-clinical colleagues. It certainly does. And in fact, I recently sent out a note to all of our faculty along these lines, pointing out that challenges to our sense of well-being right now apply across the board to all faculty and really a lot of different people in whatever type of work you're doing. But our comments today will focus primarily on clinical faculty. Also, we'll just point out by way of review from last time that really when you think about well-being, you really need to think about it as a continuum. Often we tend to think somebody's either burnout or they're not burnout. They're really struggling or they're not struggling at all. And that's really dichotomous. And what we've suggested in our prior talk, and this is going up in the literature, is that in fact, our well-being really is a continuum. It's possible for a person to be at different points along this continuum at different points in time. Our goal should be as an organization, though, to try to do everything we can to ensure that people stay to the far right of this as much as possible. And so that when they're at work or in any part of their lives, that they're in the category of well and thriving. But just know that this is not a dichotomous variable at all.
And we agree, just reviewing last week, that wellness comes in a variety of areas, and using the core wellness program model for identifying areas of wellness, we have all of these topic areas that we think are involved when we're seeking to improve the wellness of our coworkers. We've tinkered with it slightly. Normally environmental doesn't span all the other ones, but we see it more as encompassing all of the other areas. And when it comes to solutions, it's not just at the individual level, it also involves the team level and the systems level. But in the interest of time, we've selected some specific areas within each one of these three categories so that we can kind of narrow our focus today, given that we only have an hour. So the ones that have been highlighted in the respective colors are going to be the areas where we focus today.
Well, the real question is, how can we build a resilient organization? When we think about where we all work, we're all part of an academic health center, and we want to focus a bit on how can we build a resilient organization that allows everyone to be at the far right-hand side of that continuum for the majority of their time. And it's challenging to do that. It really is, because we're more than one organization involved. So it says, this is especially challenging when silos exist. I realize that the word silos has a bit of a negative connotation. So perhaps it would be better to say that part of what makes this so challenging is the fact that each of our organizations, whether it's Virginia Tech, Carilion Clinic, the medical school, Radford University, Carilion, we all have our own sort of interesting and unique goals, structures, and culture. We all have a lot in common, but we also have some things about each organization that are different. And so we want to talk a little bit about this issue of organizational culture from the very beginning of this presentation. We do this to have this as a framework in mind when you think about the materials that we present today, because this culture phenomenon is so important to this issue of well-being and burnout. So what do we mean by organizational culture? Well, here's one definition, came from the Journal of General Internal Medicine just a few years ago. As an organization's culture is manifested and sustained as everyday patterns of human interaction. For example, how one behaves in a meeting can or cannot be talked about with those in authority, who makes decisions, or how differences are handled. Culture is a field of study that has been fascinating to me for basically my entire career. I was first exposed to it very early in my PhD training, and I've thought about it a lot ever since. And organizational culture really has three components. It's made up of our underlying assumptions or beliefs about what is valuable, our organizational values and norms, and then our behaviors. This is the framework that we really would like you to think about and keep in mind, again, as we work through these slides today. Different academic health centers have vastly different cultures. I can tell you that before I came here, I spent some time a few years ago at a very high-powered Ivy League medical center in the northeast part of the country. That culture was very different than the culture here because they were focused on rankings, on being the best. And it was a very competitive sort of culture. I mean, when you walked in the doors and you were in meetings, you could feel this. It was very palpable and real. Others have a more nurturing culture. Without a doubt, culture has a lot to do with the way we do things. That's another sort of definition of organizational culture. It's, quote, how we do things around here. On how we function in our jobs and how we look at this issue in particular of vitality and well-being. Every organization also, there's not one big organizational culture that applies across the board. There are lots of different what is called microcultures within each organization. So these microcultures probably have even more of an impact. So what do I mean by that? Well, the culture of a given inpatient unit can be very different than the one on a different floor, or the culture of this department can be very different than the culture of that department. So these are microcultures, and everybody fits into one of those smaller groups of people where you actually get your work done and where you spend the most of your time. Professor Edgar Schein of MIT a few years ago wrote something about this that I think is very profound. He said, the only thing of real importance that leaders is to create and manage culture. If you manage culture, it manages you. And you may not even be aware of the extent to which this is happening. End of quote. Really something important to think about. I think this slide is really a good way to kind of depict visually what we mean by organizational culture. The things that are above the surface are the things that are easily seen. Things like slogans, ceremonies, special language that is used, how we dress, the physical settings and how they're put together, what they look like. Not easy to see, though, are those things underneath the surface, which are the underlying values and assumptions and beliefs that we might have, the attitudes we might hold, feelings of trust, issues related to transparency. These are things that are under the surface and not as easily seen. Every organization has statements of culture. Where do we find things like that? Typically, or our value statements, perhaps in our strategic plans. And those are the things that the organization says are really important. And they are really important to the organization, or they wouldn't be in those statements. But don't pay attention to the things under the surface. If you don't have that sense of trust or transparency, if you don't see that the organization is living up to its values in some way, then there could be an issue with organizational culture. This is a challenge for every organization. I do not mean to make any attributions to any particular organization. I'm simply giving you a description of what this literature is like. Now, Dr. Baird Brightman is a PhD psychologist who has written a lot about these topics, and in particular has tied this to the issue of well-being and burnout. And Dr. Brightman says that when we talk about this, we have to make the invisible visible. About burnout and issues pertaining to vitality or well-being, this is what we see. Physicians often do not want to talk about this issue for a variety of reasons. Part of it is the way they're socialized. That's probably true for other disciplines as well. We're not really socialized to talk about this. Administrators sometimes don't want to hear about it. Not always, but sometimes. And patients and payers frequently do not know about it. So how accurate this description might be depends on your particular microculture, where it is that you spend your time every day. I'm not saying this is true here across the board. I'm simply suggesting that this is one way that Dr. Brightman says that we look at it. And we have to take this matter of our organizational culture seriously and try to make the visible invisible. So to kind of sum this up, every organization has its own unique patterns or behaviors or ways of doing things. And this is a particularly important issue when we talk about well-being, vitality, or burnout. And that's the framework that we want to use to help you think about this today. Keep this framework in mind as we move through the balance of these materials.
David found this great graphic from Haydet and Stein from 2006, and it goes through some of the things, narratives that contribute to culture in medicine. Doctors don't make mistakes. Doctors must be perfect. Or there's always one right answer. uncertainty, complexity are to be avoided. It's okay to be rude when you're doing something important. Outcomes are more important than process. Doctors are married to medicine. Medicine represents a higher calling than other professions. I do believe that medicine is a calling, just as any service career is. But medicine doesn't always have to take a priority over everything else. You must not question doctors more senior than you. We have a responsibility to question people always. It's the only way we get better. So working at the individual level, one of the things that we can do to foster a healthy environment for ourselves and our colleagues is to normalize seeking support. And during the pandemic, there's been a lot of conversations around mental health, and it has helped us with normalizing asking for help. And along that way, on the recent, and during this pandemic, along that way, a recent Twitter post from Mallory Jackman, who's in Toronto, Canada, but I still wanted to point out her post because I think it speaks to what we're saying here. And she has a medical condition, both physical as well as mental, and she posted it on Twitter when she was in the hospital recently and shared her experience. And she wanted to do so as an effort to help normalize what needs to be normalized, that it is okay for doctors to get help too. It is okay for doctors to feel unwell sometimes. And so she shared this, but in this process, I'll try to sum it up as quick as I can, but she essentially said that the reason she's been reticent to share her health concerns previously is because she had negative response. However, that hasn't been the case in her current work environment, and she lauds them for their support. And further to that point, after she posted this 10 message post, she received a whole lot of really positive feedback from her Twitter, the Twitter world. And so she posted again this final message saying, thank you to everyone. I never expected to receive such a positive response. And I think that it's a testimonial to the headway that is being made. And it gets to David's point, in different subcultures, it's going just as it should. We are making headway. Key is to continue to spread this further.
Powerful story, thank you. So when we think about the individual levels of support, and support specifically for mental health, and how important it is to have a culture that provides a variety of opportunities for people to seek support for their mental health in particular, or to seek support if they're really feeling frustrated or burned out. We start with our employee assistance programs. And we're very fortunate that here in our academic health center, we have two very strong employee assistance programs. Carilion Clinic has a strong program that's made widely available. And I can't forget I can't remember the specific rules around how many sessions you have, but I think it's variable. But I know for a while that the residents, for example, had a certain number of EAP visits that they could go to without any type of charge to their insurance or anything like that. Same thing probably for other folks, but EAP is strong. EAP is strong at the university. I'm sure that they have something like this at RUC as well. So we're very fortunate that we have dedicated support professionals in these programs through either the university or through Carilion Health System or through Radford. Some people have gone a step further in terms of offering how to make this available and tried some opt-out approaches. So there are some articles in the literature you can read about where people have said, we want to assign people automatically to have 1 or 2 visits to EAP every year. Just go ahead and build it into their schedule and make it an expectation for them, and then allow them to opt out if they decide that they don't want to go. So instead of leaving it up to people to schedule it, then they schedule it for the individuals, and then they have to opt out. And this has been tried with mixed success. In some places, it's worked extremely well. In other places, it has not been as effective. But that's something that we wanted to mention. Now, for a variety of reasons, I think it's pretty clear that there is some hesitancy sometimes associated with seeking out support from employer-sponsored programs for a variety of reasons. So therefore, I think it's very important that this should not be viewed as an either-or situation. Either go to EAP or you're on your own. I think we can do better than that. I think we have to say that we need to provide a menu of choices for folks, both internal and external, so that their comfort level will match up with the resources available. If they're not comfortable seeking support from an EAP program, that's okay. Here's some other options that are available to you. Also probably true that if everybody that actually needed support all went to the EAP programs, they may not in fact have the capacity to handle that. That's another reason to make sure that we have a menu of options available for folks in this regard. Something called Safe Haven, which you can see on the left-hand side of the slide here, the different aspects of this program and what they provide, things like peer coaching, 24/7 professional support via the phone, other types of support. And this is originally put to be offered to physicians, nurses, and physician assistants. And I believe now it's also available to pharmacists, if I'm not mistaken. The cost of this is about $1 a day if you're not a member of the Medical Society of Virginia. It's less than that if you are already happen to be a member. And not only are the services provided to you, but they're also provided for your entire immediate family. And very importantly, when they put this program together, they worked with the Virginia Trial Lawyers Association to build in some protection to this so that if a clinician seeks services from this, it's protected information that you don't have to reveal it unless you're ordered to do so by a court. Now, we'll talk more a little bit about this later on in the presentation, but this is a huge issue for clinicians in terms of having a chilling effect on their willingness to seek out support. Is it going to become known? Is it confidential? Is it really confidential? So when they put this program together, they built that in, and it's really the first program like this in the country to feature that type of protection. I know we've already had colleagues here enroll in this program, and it's a very good program that is there for your consideration.
In the text, Physician Mental Health and Wellbeing, they outline a variety of different ways that we can support learners in the arena of well-being and mental health. One of the things they say straight off is start early. Start supporting medical learners in their well-being at orientation, and do it consistently from that point forward. Include stakeholders that could be when and where appropriate, that could help in this journey. It's not uncommon for family and close friends to not fully understand the medical journey, and so for a learner, and so incorporating a level of understanding for them where appropriate can go a long way in supporting the learner that they care about. Provide a variety of means. So help educate learners around mental health support from a variety of vantage points through websites and through literature and through programming opportunities that you can offer learners. Approach it from a variety of angles and keep it optional and keep it consistent. Derby did a study about a mandated well-being program, and it didn't go particularly, it didn't have particularly strong outcomes. So I think the notion there is that it needs to be an optional thing, but it also should be consistent. So when an individual is in a position where they want it, it is available, and keep it confidential. And then there's a variety of online resources through the School of Medicine Wellbeing website, and here's some links to those, and they're also available on the Virginia Tech website. But one of them is an anonymous mental health screening tool that individuals can take to ascertain what level of mental health they're currently at, and so it will give them advice about next steps that they could pursue. there's also a database of local care providers, and it's a really nice database, and the fact that it offers a variety of details relating to types of care providers you can get, as well as what insurance is covered. And so this can be particularly helpful for the medical students, for example, who are on a variety of different healthcare plans.
Really like that searchable community provider database because it enables you to search on areas of expertise. It enables you to search based on what type of insurance you have, and it returns a pretty good list of options for you based on your search criteria. So it's really powerful and a good way to get connected with local resources in this region. Thinking about the individual level, I wanted to say a word about the 20% rule. That may not be what you think of when you hear the term 20% rule. That's a business term that sometimes people will use, but this is a little different. And so I'm going to put up a couple of quotes here from studies that took place 10 years apart, but basically found the same thing. And they were in academic settings. And in particular, what they found in both instances was that physicians would report that if they could spend at least 10 to 20% of their total work time doing something that they really are passionate about or care the most about, they would experience far less risk of being of suffering from burnout or far fewer challenges to their sense of well-being. Second quote, evidence suggests that physicians who spend at least 20% of their professional effort focused on the dimension of work that they find the most meaningful are at dramatically lower risk for burnout. So I guess the question is, as we think about this as individuals, how easy or how difficult is it for me to spend at least 20% of my time on activities that I'm the most passionate about? For me, I'll give you an example. I like to write. I enjoy writing for journal articles and things like that. I don't get as much chance to do that as I used to because I have so many other demands on my time. I've often dreamed, if I could somehow find a way to block off one day a week, or at least, or even half a day a week of my calendar where I could do nothing but that. I think that would really make a positive contribution to my sense of well-being. In fact, I know it would. The same principle is true of clinicians. So I guess for us here, how important is this? Is it possible for us to do this? What would happen if you asked this question of whoever your supervisor is, or if you had a conversation with your supervisor and said, hey, what's the opportunity for me to carve out a half day a week to do this one thing that I really care the most about? Would we find that easy to do here or difficult to do here? I think that's a very important thing to think about. Now, before we finish up with this section on the individual level solutions, I just want to make the point again that we made last time, hopefully we've made today already. When we talk about individual level solutions, we do not mean to place the entire burden of dealing with the well-being on the individual. As we said in May, resilience training, mindfulness, exercise, other similar activities are all very good things to do. But you have to be careful not to place too much emphasis on that as the solution to this problem, because when you do that, you exonerate the system from any duty to address these concerns. As one writer so eloquently said, we are not going to resilience our way out of this problem. So just wanted to put that clarifier in there. There are things that we need to do for ourselves as individuals, but we have to do more than that. We have to go beyond that to look at solutions at both the team and system level. So that's where we'll go next. Focusing next on team levels, we want to start out talking about pain points. What do we mean by pain points? Well, specifically what we mean is what are some things that in your microculture or in your particular work context are the things that challenge you the most in terms of your well-being across different contexts? And it's probably also going to be very difficult, or very different across different specialties. So what are the three most difficult things for a physician might be very different than the three most difficult things for a respiratory therapist or a nurse or a psychologist, all of whom are dealing with clinical care, but who have different contexts. How to do the local work to find out what those pain points and solutions to them might be. So we did an interesting thing a while back in faculty affairs. We put this little blurb up on our website, And you see the links at the bottom. You can get to it from either one of those. Ed, we'd be happy to work with your department or your unit or your program on a very brief internal survey that would be used to identify what these things are. And one of the questions, the first question on that very brief survey is, if you could change 3 things about how work is done in your unit, what would they be? Or if you could name 3 things that you would like to see addressed in order to increase your sense of well-being, what would they be? And we had a few people who took us. We're always there. We're interested in doing this work with you, which is why we wanted to put this up. Part of what we've been able to do through that is we've been able to identify some local well-being champions. Here's a list of folks that through that work and through a previous committee, we've identified as folks in each of the departments. These are medical school departments who are very interested in this topic and would be very willing to work with you on identifying and addressing some of these very specific local issues. I do realize I left a name off this slide. I'm very sorry. I should have put Dr. Angela Nardecchia also beside Dr. Adams Banky there for psychiatry. So Angela, if you're on this call, I apologize for leaving you off there, and I will fix that before we post the slides. For well-being champions, then you can consult with them, and they will probably more than likely be willing to work with you on whatever it is that you feel would make a difference to these pain points in your particular context. So again, we also sent out a survey in January of this year to all of those departments, and we asked certain people in the departments to select the top 3 pain points or stressors that they thought affected the well-being of faculty or other folks in the department. That were identified. COVID, of course, being at the top of the list. In January of 2020, it was still raging on. It hadn't abated at all. And of course, it got a little better, and now we're back in our sort of Delta curve, Delta variant. And so it's an ongoing concern. But in January, certainly it was a big concern that people talked about. The second thing, well-being should be an agenda item for every departmental section meeting. That was a bit of a surprise, but that strikes me as something that would be relatively easy to do. Every time you have a meeting of your microculture, your team, your work unit, have an item on the agenda and just check in and say, how's everybody doing? And take a few minutes to do that. Issues related to the electronic medical record and the perfect serve system were prominent at that time, as was concern about staff turnover issues, particularly in regard to nursing. And then finally, the last item is very interesting. For some sentiment expressed, as this quote says, we're tired of talking about it, and yet it's real. And I've tried to tease out exactly what might have been meant by that. It could be a factor of survey fatigue. You know, it could be that people are tired of being surveyed about this particular topic. Or it could be something beyond that. Like the fact that some people feel like we've talked about this a lot, and now we need to perhaps let our actions catch up a little bit with our words. I think it was St. Francis of Assisi who said, preach the gospel at all times, and when necessary, use words. Well, we're sort of preaching the gospel of well-being today, and words are important, but actions are as well. And so that's why we're doing part 2, to try to give you some specific suggestions for actions and things that can be done to help address some of these concerns. One of the things that comes up quite frequently in the literature, particularly with regard to physicians and their well-being, is concern about the electronic medical record. Into this is what some people have started referring to as pajama time, which is a phenomenon where clinicians are doing their electronic charting at night. Or really early in the morning, after midnight, you know, in the early morning hours. Some systems, in fact, are now measuring this systematically. I guess there's a way you can go into the EMR and find out the actual time when people are actually doing the work inside the system. And so systems are starting to measure this, and they find that if they have too many people doing this in these off hours, they get concerned about it and want to address it in some fashion. The other thing that goes along with this is the often suggested solution is that of scribes. Scribes are non-clinician folks who have been trained to support physicians and other clinicians in documenting the details of clinical visits, often in real time. So I go to a local optometry practice here, and I get my eyes checked a couple of times a year. And every time that I'm having an eye exam, there's two people in the room, the person who's doing the exam and another person who's sitting at the computer, and the person doing the exam is talking out loud with the findings and saying, okay, right eye this, that. But that person's not doing the charting. The other person in the room is writing it all or typing it all into the record. So this is the way that the scribe system would work. This is something that is suggested quite frequently in the literature as a potential solution. This often can result in lower documentation burden for clinician, more opportunity for clinician-patient interaction. I know if you're like me, you hate to go and when you see your physician, you don't want to see that person spend a lot of time looking at the computer screen. You'd rather they be looking at you and talking with you. And I know that that's challenging sometimes, but that's just the way a lot of patients feel. So this might be a potential solution to that. It could help mitigate clinician burnout. Sometimes it involves aspiring medical students, which strikes me as a win-win. If you can get medical students or people who are trying to become medical students to do this, they learn a lot about clinical medicine just by doing it. It increases their opportunities perhaps to be admitted to medical school if they have this type of experience. And then it also provides a much needed service for the clinicians who are doing the actual patient care. Certainly can work better in some practice settings than others. It's more challenging to implement in some settings. And of course, you have to demonstrate that it's cost effective. I don't really know that much about our use of scribes in our system here, but we simply throw this out as an option of something that we should seriously consider. And I know that a couple of our departments are using scribes, at least in a limited fashion. Another oriented intervention that we wanted to talk about today is peer support. So again, I'm going to put a couple of blurbs up here about some peer support mechanisms that we have in place. We are very, very fortunate at Carilion to have something called the trust team. If we were in person, I might ask for a show of hands to see who all is familiar with this. The trust team is a program that is set up to respond, to provide support for clinicians when they're experiencing difficult patient outcomes, and in particular, when the possibility of a near miss or an actual medical error has occurred. Sometimes these circumstances can be very, very devastating for clinicians. And so the trust team has been specifically set up to respond to those type of situations. And we are on the cutting edge. There was recently a review article that came out summarizing what is known about this. And it's still true that there are a relatively small number of health systems who offer a trust team or second victim type program. So we're very fortunate to have that here. Also, we have something relatively new at Carilion called Code Lavender, which is somewhat similar to the trust team in that it's a holistic, rapid response to very emotionally stressful events. These are usually ongoing, like you would call a Code Lavender when something is literally taking place at the moment, sort of real time. Help you and be there to support you and help you think your way through whatever those circumstances are. Offered primarily right now through the pastoral care services at Carilion. And I believe this is a relatively new program, but it's something that has happened in a lot of other health systems. And I think it's a very, very healthy and helpful response. A lot have been written about peer support for clinicians. Here's a reference to an early article that talks about a program at Mass General Hospital in Boston. The issue here is the question of who is my peer? There's some evidence that certain groups prefer to talk only to other people in that same group. So for example, you might speculate that when physicians are experiencing a difficult outcome or they really need support, they would prefer to talk to physicians. Nurses may prefer to talk to other nurses. This is a preference. This makes sense when you think about things like social identity theory, which talks about how group membership has a powerful impact on the preferences and behaviors of people who are members of that particular group. I don't think this is either good or bad. I think it just is. I think we have to recognize it though, and we have to make sure that, again, our programs are in place accordingly. If we have physicians who prefer to get their peer support from other physicians, I think it's our obligation to identify a group of physicians who are willing to do that. Same thing with nurses, same thing with other disciplines. Another form of peer support is the Carilion Clinic Moral Distress Consult Service. So some of you may know about this, some of you may not. Again, very innovative, I think very cutting edge. Not very many health systems have this. So moral distress is a situation where you feel like you're in a situation where you know the ethically appropriate action to take, but for various reasons you're unable to follow your ethical instincts there. It can happen not deliberately, but according to circumstances. So the COVID crisis has been a very good example of this, where in the early days, there were many health systems that did not quite have enough PPE on hand, enough particular types of services or care to provide for overwhelming numbers of patients. Where you saw this in other countries where doctors were literally having to make life and death decisions about who they could give a limited treatment to in the face of these enormous COVID challenges. This undoubtedly contributes to a sense of moral distress. And so if this happens to you, just know that there is this moral distress consult service available to you through the Carilion Perfect Serve system. So you activate it that way and ask for a moral distress consultation. Another program that is relatively recent was just started by our own Dr. Mark Greenewald, I think about not quite 2 years ago, is the PRX MD program. This is based on the principle that no one cares alone and that you should have a buddy or someone that you can turn to. So the way this works, you sign up with another person and it's completely up to you. It's completely voluntary, but the system will send you reminders every week and a suggested way that you can connect with your buddy and just check in with each other. And there are different levels. You know, you check in once a week for maybe a minute or two. You check in every 3 months for longer than that. And then maybe every 6 months, you try to have lunch or something. It's a very structured program, but again, it's all voluntary, but it's designed to meet a specific need. And it's based on this profoundly important idea that no one should care alone. So this is a really innovative thing, and I would encourage you to check this out at this website if you feel so inclined.
Here's a variety of resources we're implementing at the School of Medicine for the medical students. This slide is a hybrid of both recommendations from the Physician Mental Health and Wellbeing book, as well as what we're actually doing. And the text recommends to engage students in learning opportunities developed to offer tools to provide peer support while maintaining healthy boundaries. And along that line, we have an M1, M2 mentoring program where M2s receive an M1 mentee upon that M1's arrival at orientation. And those pairings very customarily last throughout the student's 4 years of medical school and probably beyond. They support each other with day-to-day questions as well as emotional support as well. There's a peer educator program that's continues to get more and more robust at the school, which I find incredibly wonderful because it's also an indication of medical students being willing to ask for help from somebody when they are struggling academically. Our students can receive one-on-one peer support, or they can attend small group sessions that are led by a more upper-level medical student. And so it also gives learners the opportunity to practice their medical educator skills early on in their medical education, which has long-term benefits as well. And then there's also, the book recommends upper-level peer panels on a variety of different topics. And we also have those as well for our students. And we have panels anywhere from step 1, step 2 prep to transition to residency, a variety of things throughout the student experience. And the last topic is mentoring communities, and many of you may be familiar with that already. It's a new program at the school. We used to have our physician thought leader communities, and that has transitioned into the mentoring communities, and it really gives students an opportunity to connect in a a long-term way with individuals at different stages of the medical education process, from medical student to resident to attending. And so variety of supports there.
Okay, so we want to turn now to system level issues. And we want to start by talking a bit about measurement. First thing we want to say about this is that we measure what we value. About this is that we measure what we value. A couple of quotes here from some very prominent folks who have been at this for a while, and these are kind of self-explanatory. Lots of calls for us to measure systematically the health and well-being of our clinicians in particular, and I would suggest all faculty. And then not just to measure it, but to report it in a transparent fashion. Dr. Sinsky writes in a very influential report that was published in November from the National Academy of Medicine that organizations should be transparent regarding the results of what they measured. She goes on to suggest in that report some things that we should measure: well-being and burnout, leadership quality, efficiency of the practice environment, culture and trust in the organization, the organizational cost of burnout. There are formulas one can use now to put a dollar figure on what it costs systems when they have a high level of burnout. Workforce retention. These are all things that must be measured. Now, there's another one that I thought was quite creative that was done a couple of 3 years ago by a health system in Hawaii. And they came up with this idea of, quote, let's get rid of stupid stuff. And so what they did, they asked clinicians, I think it was about 150, 200 clinicians, and they said, in your particular microculture or your particular work unit, can you suggest some policies or tasks that could be eliminated in order to gain efficiency? And they thought they might get a handful of suggestions, and they got over 300 from physicians and nurses in that health system. And this was published in the New England Journal about 3 years ago. So very, very cool idea. Have we thought about doing something like that here? Could we do this here? Could you do it in a unit? Maybe that would help. Maybe it would identify some things that could easily be could easily be eliminated and reduce everybody's frustration level a bit. Another very important system level issue is this matter of licensing and credentialing. So I mentioned earlier that one of the concerns that clinicians have about seeking support for mental health concerns or burnout or things like that is the concern over the confidentiality and what who might know about that and what impact this could potentially have on their licensing or credentialing processes. So there's a lot been written about this. We don't have time to go into a lot of detail, but I really like the way that the Korean Medical Center words this on the credentialing application, which you can read there on the left. The licensing boards still have some work to do in certain parts of the country. So a lot of times when a clinician is applying for a license, they'll be asked a question, something along the lines of what you see in the right-hand side. The better way to ask it is, do you currently have a medical or physical condition that impairs your ability to practice medicine? That's a yes or no that reflects the current condition. What many of these questions will ask, though, is have you ever been treated or counseled for any type of mental, emotional, or other similar problems, or within some time frame, within the last 5 years, within the last 10 years? These questions have a profound chilling effect on the willingness of people to seek assistance. And in fact, there is some feeling now that some of these questions are probably unlawful as under the Americans with Disabilities Act. So there was a paper that was published not long ago about this, actually in May of 2021 in JAMA, and each state licensing board was given a 1 to 4 rating, where 4 was indicative of implementing all 4 recommendations from the Federation of State Medical Boards about how to word these types of questions. So if you got a 4 for doing it, for addressing all 4 of the concerns, and you got a 1 if you only address one of them. Virginia was rated at 2. So this is an issue that perhaps we can make some progress on in Virginia, and perhaps we could show some traction on that. Again, I'm not going to read this out entirely, but what this basically, again, from that very influential National Academy of Medicine report, repeats all for health systems to have a chief wellness or a chief well-being officer. It's very simple. Those organizations that do that, according to this report, will be more impactful than those whose investment is limited to informal champions and standalone committees. Without a chief well-being officer, ad hoc efforts to support clinician well-being often result in siloed initiatives and frustrated efforts. I think it's past time for us to appoint a chief well-being officer for our system. I really do. I think it's time that we take that step and make sure that that person is given the title and the adequate resources and the time necessary to really make this an area of focus moving forward. On leadership is more what you might be thinking of when you think of leadership. So this is an interesting study that was published in 2015 about a survey work that was done at Mayo Clinic with 2,800 physicians who were surveyed at the same time about their perceptions around leadership furnished by their immediate supervisor, as well as their current risk for burnout. And what they found is that there was a correlation between those two things. At every 1 point increase in the leadership score of a physician's immediate supervisor was associated with a reduction of 3.3% in the likelihood of burnout. That's pretty important. So it's a relationship between type of your feeling of well-being or burnout. According to their study, there might be. So somebody could say, well, how did they measure leadership? These questions that they use. So again, you can look that study up and read about it. Our question is, are we doing anything like that here? I'm sure that we are. We have a new leadership institute through Carilion. The university does a lot of work in leadership development. Are we making the connection, though, between leadership and well-being? I hope that we probably can make some progress in this regard.
And at the medical school level, things that are recommendations, things that administrators can do is provide resources to your faculty. It's possible that they don't have the skill set or the experience in this realm that they would like to have. And so empower them by providing them with the education and the training that they need. Incorporate well-being elements into curricular places where it makes sense, just nested in with other topics when it logically flows. Provide learning and working supportive environments. And so meaning, is there a gym accessible to your medical professionals and learners? Are there healthy diet options available to them? Are there spaces and places they can go if they want to have mindfulness or meditation practice, those types of things. Provide learners at all levels, again, optional educational programming covering topics that will help them as they move forward in their journey. And some of the topics that contribute to burnout include cognitive distortions, maladaptive perfectionism, imposter phenomena, but there's a variety of other things that lead to burnout beyond those individual topics, but those are some examples. And then reflect on the importance and the message that it sends to individuals when individuals in positions of authority participate in these events as well. This is just a list of some of the things that we're doing at the medical school level to this end as it relates to some of those healthy educational programming opportunities for our learners. There are a variety of models out there. We do not have to recreate this wheel. It exists and it is strong in a variety of programs. And these are 3 exemplar programs that we encourage folks who are interested in this topic to explore because they have great ideas. And incidentally, they all have chief wellness officers. So the IACAN School of Medicine, the Stanford School of Medicine, and then the Mayo Clinic are 3 outstanding programs.
I wanted to say something about the Stanford program. They came up with a really innovative way to work with with their various departments. And they came up with a time banking system. So I think you can probably read about this on their website. But what they did, they went to the faculty in each department and they said, would you come up with a list of things that you feel like should be rewarded because people have really gone the extra mile? So it was a way to recognize people for doing positive things. And then they came up with a way to be able to give faculty credits for doing those things. And then they could use those credits in exchange for very specific designated things like tangible goods and service, such as childcare, delivered meals, et cetera. And things on that list included things like agreeing to take a call at the last minute or covering for a colleague when they wanted to be with their child for a school-related event, something along those lines. So they came up with this very innovative time banking system, and they studied over a period of a couple of years, and they found that it not only resulted in a better sense of well-being, but it also actually led to an increased research productivity as well, in terms of both obtaining grant funds as well as just being able to conduct research. So they're all in on that. And I thought it was just a marvelous example of a very specific program that could be emulated quite easily. It would require an investment of resources to furnish those very tangible things, but it might be worth it. Okay, so here's our summary slide. We're almost at the end. Talked about a lot of these things already, but I think number one, we have to recognize that well-being deserves a high priority. I don't think there's any question in my mind that we recognize that here in our health system. Things that we have in place. It's obvious that this is something that people care about. I think we can do more. And I think part of what we hope to convey today was some specific suggestions around how we could be even more effective than we are now and do some things that we're not doing now that will make this even better. We have to make it normal to talk about this. You know, you go back to that idea of culture and what can and can't be talked about. We have to somehow overcome that if it's a barrier in your particular microculture. We have to make it normal to check in with each other and say, how are you doing? And not be afraid to really tell somebody, I really need your support. I need some help. Figure that out. Provide a comprehensive menu of services or resources, both internal and external, and make them easy to find and talk about them frequently. As a leader, make it your duty to find out what is the 20% of people, 20% that really satisfies the people that work with you. Exercise is something we could think about related to that. Within your own area of influence and your identified champions to address the 3 issues that are most important in your particular unit or microculture. If you don't have a champion, think about being one yourself. Presence on this in this meeting today indicates that you're interested in this. You could be a champion. Measure, 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 and report the results. Be transparent about what the results are. Find and use a peer support mechanism that works best for you. Name a chief well-being officer and provide that person with the needed time and resources to really make this area move ahead in our system. And then finally, work hard to change our overall organizational culture and make it even stronger around these issues pertaining to faculty well-being. ARM Charter, this is something that the American Medical Association came out with a couple of years ago. Our medical school is signed on as a sponsoring member. You can read that. Sum up, we have made some good progress since we first started talking about this in 2014. And we have developed some great resources over the past 5 years. Are we doing enough? I don't think so. I think we can do better. And we try to be very concrete and very specific about some suggested ways that we could do even better than we are doing now in this regard. Only time will tell whether we're willing to devote the time and the resources needed to do that.
We just want to conclude today with a list of various resources for folks to check out at their leisure. And please don't hesitate to reach out to David or myself if you have any questions or you'd like to keep this dialogue going.
Thank you both so much for this fabulous session, and I really appreciate it. I hope others do. Continuing this important discussion, really providing local resources and potential solutions. There were a couple of comments in the chat. One was earlier on when we were talking about individual issues. So the problem with the EMR is not just the burden of documentation. It is in the reading. It is so overloaded with junk that it takes too long to review it all. Mistakes get made, mistakes of omission. I am absolutely convinced that the EMR causes as many errors as it stops. And that is certainly not a localized problem. That is a national issue. Do you all have any comments on that, David or Emily?
I think you're right. It's certainly not a local issue, and it's one that is hard to wrap your head around and really do something about, because it works so differently in different contexts. I know this was probably 3 years or so ago. We had somebody come here from a different health system. So this was not in our health system. This was a person who worked in a different health system in a long-term care setting. And describing how many clicks it took in their version of the EMR to order 2 Tylenol for a patient. And it was something like 45 clicks or something like that. And he was saying, this is absurd, you know, and they were trying to figure out what to do about it and how to address it. And I'm sure they probably eventually made a way to streamline that, but it's a huge problem that clinicians talk about all the time.
Well, I hope this helped to meet the requested needs of the folks who were chanting in unison, we need a second session. And we will continue to offer these sessions and other things that are valuable to you if you speak up and let us know what is important to you all and what you all desire. We have another comment here. We really need a champion that can provide these services to nursing and ancillary departments as well. Someone that can help the administration see the value in these services and the value in their staff, whereas it always seems to be the bottom line. Thank you for that comment. Anything else? Anything else before we let y'all get back to your work? Thank you all so much. Emily and David are always available, and this is always something that they want to talk about. And they've provided with you with a ton of resources that you can also look into if you so desire. Please continue the conversation. Keep it transparent. Thank you all. Have a great day.